Okay, so I'll start now, if you can hear me well, everybody.
Yeah.
All right, you're most welcome. And actually, I would like first, very happy to be with you today. I would like first to thank the University of Damascus for this invitation, actually. And I would like to thank Professor Usama Al-Jabban, the Dean of the Dental School, for this invitation. I would also like to thank Dr. Anas Abdo for liaising and coordinating this online scientific meeting. I would like to start the topic for today concerning how far should we instrument the canal and where should we place the root canal filling material. Can you see the slides?
Yep, perfect.
All right, great. So I will start here by reminding
all the people and the audience, and we are seeing the slides of you.
All right,
Tayyan. You can
thank
go
you.
ahead.
So basically, I would like here to remind the audience here with the main goal of root canal treatment. As you know, that the root canal treatment is to clean. The main goal is to clean and obturate the root canal entirely. And I would say that the root canal treatment is like a game in which we try to overcome all the difficulties in our way to the apex. And here I would raise the first question concerning where does the apex end? In fact, we do have many levels to end up with. And this question has been for a long time a big debate among clinicians and researchers, because we do have many levels as the minor apical foramen, as you can see, the apical constriction, the cementum dentinal junction, the radiographic apex, and the major apical foramen. In fact, I would like to share one of my clinical cases here. I'm sharing this case not because of the separated instrument in the mesiobuccal and distobuccal canals, but because of the different levels of obturation. As you can see here, we do have different level of obturation. As you can see, I'm not sure if the cursor is clear in here, but what I finished is distobuccal was a little bit short in here. The mesiobuccal was a little bit beyond the apex, and as you can see that the palatal canal was right to the apex. What level is the best? In fact, there has been a lot of research in the literature concerning the level of instrumentation and obturation of the root canal and its effect on outcomes. In fact, most of these research refer that the best way or the best outcomes were achieved when you fill within the last 2 millimeters from the apex, comparing with being short of 2 millimeters or being outside the apex or filling beyond the apex. It is advocated to fill 1 to 2 millimeters short in vital cases and to be half to 1 millimeter in necrosis cases with apical periodontitis where there is cemental resorption, as you can see here. At my clinic, I do my best to respect the periodontal tissue and to fill within the confine of the root canal, trying to be within 2 millimeters from the apex. I have a good friend at my clinic. Actually, the apex locator can always guide me and show me where to finish, to what level can I finish my obturation. It's been of big help always. And this is a C-shaped canal. This is one of the interesting cases. In fact, I would like to share this case because this case was a lower left 6 with a separated instrument in the apical part of the mesiobuccal canal, actually. The approach was to bypass the separated instrument, but unfortunately wasn't really able to control the apex. So I pushed some material outside the canal and the separated instrument was pushed around 1 millimeter beyond the apex, as you can see here, because of the apical resorption on both roots. And I would like really here to emphasize or basically to remind you with the difference between being overfilled or overextension. Actually, the difference between both of them, I mean, both the filling and overextension refer to filling beyond the apex. Well, the only difference is in overfilling, you maintain a good sealing at the apex. And I believe that this is what happened in this case. So I didn't send the case to the surgeon. What I did is I recalled the case after 12 months, and I was very happy really to see the outcome here. It just starts healing very well. And I would like really to remind you that filling beyond the apex does not always stop healing a process. It might affect in a way, or maybe it does lower the percentage of healing in a way. It might delay the healing process, but it does not always stop healing the process. Another case I would like to share with you here, very interesting one as well. Lower right 5. This lower right 5, as you can see, with a very big and large canal, very poor quality root canal filling with overextension. As you can see, this is a good example of the overextension. As you can see, there is no good seal here at all. And there is a GP cone extended outside in the apical bone. I failed to retrieve the extruded apical cone, and it was left in the bone. And here I'm trying to gauge the apex, as you can see here. The apex was very big. In fact, so what I did is I placed bioceramic putty material in the last apical part of the canal, around 4 millimeter from the 4 millimeter at the apical aspect. I was a little bit short here. Do you think that I'm short in here? I left the GP cone outside in the bone. And this is the case after being finished and referred back to the referral doctor. I was lucky enough to see the patient after 24 months. And as you can see, it was really amazing result here. We did have a very nice healing here, and with a fully cementum closure at the apex. And this is the GP cone has disappeared as well. This is the pre-operative X-ray, and this is a post-op X-ray. I would like here to remind you that when we respect the periodontal tissue in order to get respected outcomes, so we really need to respect the periodontal tissue. In fact, we do come across lateral canals from a while to another during the obturation or after obturation. They look very nice at the post-operative X-ray. Sometimes we can predict the existence of the lateral canal when we see this lateral lesion. So we can predict the existence of them. As you can see, they look nice at the X-ray. And there's been a lot of research in the literature concerning the investigation of filling these lateral canals. This is, I suppose, an Italian study. Another Brazilian study here tried to compare many or different techniques in filling these lateral ramifications of the root canal. And this is Turkish study. In fact, a very nice paper was published in the Journal of Endodontics in 2010, has questioned the fate of the tissue in lateral canals and apical ramification in necrotic cases and after root canal treatment. In fact, this paper was proposed or presented by Domenico Ricucci, and I'm very happy that Dr. Ricucci is with us today so he can share us his own experience in this field. And he might be able even to ask or to answer for some of the question that I prepared concerning how far should we instrument the canal, where should the canal filling material be placed, do lateral canals really matter? And I would like also really to share some experience from Dr. Diego Guerrier concerning his own experience with the approaches to achieve good root canal obturation. You are most welcome, doctors. And actually, I will stop here. And thank you for being good listeners. I will share the screen now with Dr. Ricucci. Dr. Ikuji.
Thank you. But I have a message that my share screen is disabled by someone. Now, can you?
Just if you try
Okay.
it again, please. Okay. Okay.
I think now it's okay.
Okay. Now we get it, I suppose. Yes.
Can you see my screen now?
For sure. We can see you very well now.
Okay, very good.
Thank you.
Okay, so I am going on for 45, 50 minutes, and then you said there are questions.
Okay, sure.
Okay, so I would like to thank Anas Abdo and Dr. Tayyan for the invitation. It is for me a great pleasure to be here. So I'm going to discuss lateral canal and apical terminus. So let me tell you that it would take me 1 week to fully discuss this topic, but unfortunately in 15 minutes, I think I can just give you an overview of the story. So I'm going to use some histology because when we look at a radiograph, and we may have different opinion, when you have a properly cut, stain, and histologic section, then there are no more opinion, but there are only facts. So this is the importance and the beauty of histology. So I have, as you may know, I have a laboratory, histologic laboratory in my practice, and I have the possibility to process specimens coming from the clinic. So I'm going to use also some histology. The serial sectioning procedure is so important. If we cannot cut random section, and then we stay in the sections and we observe. Now I will try to show you what happened in lateral canal, in normality and in pathology. So to feel or not to feel, is this the question? And I know that every clinician is happy and proud to get this kind of images radiographically or in clear teeth, showing that melted gutta percha by worm or by solvent can potentially penetrate in these spaces. Yeah, actually, if you push, they can penetrate. But is this biologically acceptable? Or is this something that clinicians like to show excellence in endodontics? So there is a great misunderstanding that this kind of treatment are believed to be the excellence today in endodontics. And that the big problem is Facebook today, is internet, because if you go in internet, I took by chance some cases, so I hope that nobody will be offended because there could be the odor among the audience here, but I took by chance just to show this. These cases are presented as, you know, to show, look how good I am. I was able to fill 3 ramifications, and then I was able to scout a canal and so on. Well, let me tell you, this is the disaster in endodontics that we are living today. I'm sorry if I am politically incorrect, extremely incorrect, but this is the story. So is that so important and relevant to get this picture? And unfortunately, this is the mainstream. And let me tell you that universities are mainly responsible for this disaster. Okay. So let me show you. I promised you to tell you what happened in lateral canals, and we start from the moment that a caries is penetrating in the pulp chamber. So there is a necrosis. Things are not black or white in histology and in the human teeth. So you don't have vital or necrotic. So the necrosis goes slowly in an apical direction. Here, the pulp chamber is exposed. Many patients do not want the tooth treated, so some teeth are extracted, and the tooth is there. You see necrosis in the pulp chamber, necrosis in the orifice. And pay attention, you have a periapical lesion here. So you may think the pulp is entirely necrotic, but if you look at the transition from coronal third to middle third, it is there and it is there. And particularly if I stain for bacteria, bacteria are stained blue or red, so you have a lot of biofilms in the coronal third, but suddenly you have a transition and you have no more bacteria. What does it mean? It means that you have vital inflamed tissue, inflammatory tissue facing the infection. So if you have, now let's imagine, if you have a lateral canal originating from the main canal, what is the status of the tissue in the lateral canal? Well, it reflects the condition of the tissue in the main canal. So if you have necrosis in the main canal, you will have necrosis in the lateral canal. If the canal originates in an area where there is inflammation, there will be inflammation. If it originates where there is vital tissue, you will have vital tissue. But remember that the circulation for the lateral canals originates from the periodontal ligament. So the blood comes from outside to inside. I have a question for you. Do you see here any ramification here? The diagnosis here is irreversible pulpitis. So it means that the pulp is vital and there is some necrotic area only in the chamber. Obviously, you don't see any ramification. Again, some teeth are sometimes extracted because of the patient. And despite you don't see any lateral canals, you have it in this tooth. There was mid-root here, there was a ramification. Now, the pulp was vital, as I told you, although inflamed. Now, what is the condition of the tissue here? You have vital tissue with some diffuse calcification in the main canal, and you have vital tissue in the lateral canal. So, if you recognize the inflammatory cells, if you know them, you will not find a single inflammatory cell here. Now, please, in a vital case, tell me, is there a single reason why you should try to remove the tissue in the lateral canal and to fill the space? No, not at all, because the blood is originating from the periodontal ligament. So when, first of all, you don't know that you have this anatomical condition in the particular case. Secondly, when you instrument the main canal, you are producing a wound at this level. So contrary to what I told you, in many of these cases showing lateral canal beautifully filled, there is not a periapical lesion, there is not a lateral lesion. So presumably the pulp was vital before the treatment. So if the pulp is vital before the treatment, please don't do this. This is totally biologically wrong to obtain these things and we have to say that clearly, including scouting. What does it mean, scouting, trying to enter in one of the many lateral canals? It means nothing. It is time that clinicians start to learn biology if they want to do something good for the patient. So let me use this drawing on a histologic slide. You have 1 + 2 + 3. This is the surface produced when you instrument a canal. The surface with the human body, the surface with the pulp tissue. Now, if you stay inside the canal, as I told you, imagine here you have 3 wounds. Now, the surface of the wound is X. But if you squeeze material, if you push material into ramifications and you go beyond the apical constriction, the surface in contact with the connective tissue will be enormously increased. So pay attention. I'm not telling you that you are killing the patient. You don't kill the patient. And even these cases may potentially heal in the absence of infection. And they will be asymptomatic. But a basic principle of wound healing is keep the wound as small as possible. So, and you keep the wound small in the first case, not in the second case. So this is totally unnecessary for the healing. And again, this may appear beautiful in the X-ray, and please many people, but unfortunately, I say endodontics has taken a wrong path. I know that this is the mainstream, and I am totally against the mainstream. Not me, biology is against the mainstream. So you can ask me, is there any histological evidence? Yeah, it was published 10 years ago. And I can show you what happened. Now, there is vital pulp in this maxillary incisor. It was treated. I treated it approximately 1.5 millimeters short, no squeezing in any ramification. 6 years, everything is fine. 10 years, large caries here. The prognosis is not good. 13 years, the patient has to remove the teeth because they are no longer restorable. But pay attention, the periapical area is absolutely healthy radiographically, and it is symptomless. So this is what we call clinical and radiographic success. I do repeat, preoperative radiograph was, preoperative diagnosis was vital pulp tissue, okay? Now, you have the histology here. You couldn't see ramification in the radiograph, but you have ramifications in the histology. At least you have 1, 2, 3, and this is the wound healing here. Now, what is the condition of the tissue? Here, what do you have here? You have hemorrhage because of the extraction. And once again, after 13 years, I invite you to find a single inflammatory cell here, just connective tissue. So what does it mean? It means that instrumenting at the apical constriction, the operator didn't know that there are ramifications, but they are always there. So they were preserved by a cautious instrumentation. The filling did not interfere with the connective tissue, and after 13 years, the tissue in the lateral canals and ramification is totally uninflamed and healthy. This is what we want. This is what biology wants. Now, the next step is when there is inflammation in the main canal, and obviously, what do you find in the ramification? You find inflammation. So inflammation does not mean necrosis, pay attention. And here you have an inflammatory stimulus, and you can see proliferation of epithelial cells in this large lateral canals, okay? So once again, but then you have the next condition, because if the condition is not treated, bacteria will colonize everything. So if you have severe infection in the main canal, there will be a moment in cases with long-standing necrosis where there will be necrosis and infection in the ramifications. And now the problem is, this is a clinical problem, because the question is, can we clean those spaces with our contemporary procedure? And I anticipate to you, no. Unfortunately, when we have these extreme preoperative conditions, there is no possibility to get rid of bacteria in this position. And then we have another, let me show you another extreme condition, long-standing necrosis. The apical canal is filled with a biofilm, and magnifying here, the foramen is anticipated, but look at this, there is a tiny ramifications. What is inside? There is another biofilm. So with the root canal treatment, we can clean the main canal, including the severe infection in the main canal, but we will never be able to remove the biofilm in this tiny ramification. So these are the cases that are going to fail. We can only accept the fail. So it is certainly desirable to clean lateral canals and ramification from necrotic tissue, but can this be achieved? And we have to be realistic. And we use a lot of histology of failed cases showing that the failure is caused by bacterial persistence in these spaces. So you understand that a recurrent canal like this is the entrance, the canal does like this. So you have necrosis and bacteria in the main canal, you have necrosis here, there is no way. So the irrigant solution cannot circulate into these spaces and get rid of bacteria. Extreme condition, you have a lateral lesion, you don't see lateral canals in the radiograph, but in histology, yes. And this is unbelievable because you have one ramification here and one more coronally, and the two ramifications join together. This is unbelievable. What is inside? Inside there is a thick bacterial biofilm, and once again, we expect that this cannot be eliminated with instrumentation of the main canal. So at this point, you may ask me, okay, but if I cannot remove the biofilm and bacteria with the conventional instrumentation, then I can push material. Maybe I can kill those bacteria with my obturation material, and some sealers, they have antibacterial activity. So is this a good idea? Not at all. Because when you push material, and now you will be impressed. This case, there is a lateral lesion. The case was necrotic, at least the diagnosis. You see some material in one ramification, okay? And then the follow-up up to 11 years, then the tooth was lost because of destructive caries, okay? The tooth is lost, but radiographically, it's okay. At this point, we don't see the canal any longer, but the canal was there, and there is a step during histological processing that the tooth is clear, and at this point, it seems that the canal is filled with gutta percha, because the technique used here was lateral compaction modified with chloroform, so softening gutta percha may penetrate. So if I stop the analysis of this tooth here, you may think, oh, Very good. You have been filling the lateral canal here and the other ramification here with good aperture, if you look at this photograph. But if you look at the histology, sections cut through this lateral canal, the picture is totally different, because the black brown material is the obturation material, but this is not filling the space, because you see that you have a soft tissue and you have inflammatory tissue. So pay attention, this is important. This is clearing teeth is just a game. Only histology can tell you the reality of the tissue. So despite it seems to be filled here, in the reality it is not filled, and you can only squeeze the material. And in doing so, you are not killing bacteria. On the other side, there will be cases in which you have a lateral lesion. You expect that there are one or more ramifications maintaining the lateral lesion. You finish your instrumentation, and many people will be disappointed, many colleagues, because, oh, this is not going to heal. But despite that, the case healed beautifully. So what is the explanation for that? And then people are crazy. No, there is always a biological explanation. And the explanation here, let me use, well, this histology does not come from this case, because I couldn't extract the healed case. But the only explanation to explain the lateral lesion and the healing is that there was necrosis in the main canal, but there was a lateral canal, and the tissue in the lateral canal was not necrotic, although inflamed, and was not infected. So the lateral canal here, they are just transporting, they are just diffusing the toxins, the bacteria byproducts from the main canal. The endo treatment was removing bacteria from the main canal, and the aggression of bacteria byproduct just ceased, and with the beautiful healing. So there will be other cases in which working length lateral lesion, when you feel, obviously, you will see some material. This is my case. So I use lateral compaction, cold lateral compaction. So this could be serious. So when this happens, I'm not happy and I am not sad. We only accept that some fluid, the fluid phase of your obturation system can flow in these spaces. So I don't want to do that, but if it happens, I'm not very sad. So what is the fate of that? It is healing, but this is not because I was able to squeeze some sealer into the ramification. This is healing because you are fighting the infection from the canal. This is so important. So the condition of the lateral canals, very seldom they harbor necrotic and necrotic tissue and biofilm, very seldom. And in those cases, it is very hard to remove them. Let me show you a complex clinical case. There was a long-standing sinus tract, a big lesion here. So you start to do working length instrumentation, calcium hydroxide medication, and after 5 sittings and 5 revision of the canal, there was always pus originating and exiting from the sinus tract. So despite 106 days of calcium hydroxide, so this is a short-term failure. This is a case that does not respond to any treatment. What is the possibility here? The only possibility you see pus from the sinus tract and pus from the canal. So at this point, the only possibility to solve the case would be surgery. But before surgery, you have to fill the canal. I took a CBCT, and you can see that the lesion is very big, and sagittal scans show the absence of cortical bone here. So I filled the canal the evening before, and the surgery was scheduled in the morning later. So there was I placed a glass fiber post and build up in a temporary ground. You see the sinus tract. So you select your incision because you have a periodontal recession here, and this is the incision. And this you can see when elevating the flap, you see that there is no more bone. The lesion was probably a cyst, apical resection here. The soft tissue was removed. Now retrocavity preparation with ultrasonic tips and filling with MTA, the suture, the post-op, and now this is the healing of the sinus tract. This is after 12 weeks. 12 weeks, okay. And And now this is the post-op, and this is 1 year, and this is 3 years later. So this is a fantastic healing after 1 year. And this is what we do expect. So remember, this case was not responding to orthograde treatment, and it responded to surgical treatment. Until here, this is exactly what we do, our protocols, what we do expect. Now, since we have the tissue, we have the big lesion, let's analyze what is the reason for that. And we analyze the cyst wall. This is the cyst wall, and you have here just the epithelial lining, which is highly inflamed. This does not explain the reason for the failure. We need to investigate, particularly for bacteria, the root tip. And if you look carefully at the spot, this seems to be a ramification. And after clearing, before sectioning, yes, it is a large ramification. Now, I decided to take cross-section passing through the ramification there. And here you have stain for bacteria. So look carefully. The main canal was instrumented up to number 90. Okay, this is an incisor, so not a big scandal. We try to remove bacteria from the main canal. And irrigation and calcium hydroxide medication, they were able to remove and to clean half of the course of the lateral canals. But the distal portion of the lateral canal still harbors biofilms and bacteria. And pay attention, this biofilm is undisturbed. And the biofilm is starting to grow on the external apical surface. So this is the beginning of what? Extraradicular infection. So with this, you understand, with this examination, histology, you understand why we failed. We failed because despite all our attempts, the irrigant solution could not circulate into the ramification and clean it, okay? So, and the healing took place just because we removed the apical portion with the location of infection. It's so simple. So you have to regard to the apical surgery as the natural continuation of the orthograde treatment. Okay. Once again, I do repeat that when you squeeze with warm gutta percha, for example, this case clinically was done by Jorge Vera, my friend in Mexico, in teeth, human teeth, that could not be saved. It was just an experimental treatment, and you can see there was a warm gutta percha squeezed into a large ramification. The tooth was extracted, and this is after clearing. There are 2 ramifications. Now, as I told you before, this seems to be filled by gutta percha. But now we cut cross-section showing the several levels of the ramification. Let me show you the details. Halfway of this ramification, it is there. Now, the brown material is the gutta percha and the sealer. Look at the biofilm. This is just depressing. So it is depressing because the obturation material squeezed into the ramification did not exert any effect on the biofilm. The biofilm is absolutely undisturbed by the obturation, by the squeezing of obturation material. So please, filling lateral canals in necrotic cases with the idea to get a bactericidal effect is just an illusion. So you don't succeed. So there is no clinical or histological reason to believe that forcing filling materials into ramification is necessary for improved treatment outcome. Obviously, it is desirable. It is desirable, obviously, to find in the future new devices, new chemical products, new physical energy to get rid of the bacteria into these complex spaces. But in general, you have to understand that today we can clean just the entrance of the lateral canals. But remember, because the nature is helping us, because many cases heal, and they heal because the necrosis and infection of these complex spaces is quite uncommon, okay? It needs a lot of time. Most of the time you have the lateral lesion and the tissue in the lateral ramification is not necrotic and it is not infected. In those cases, we have the clinical success. And unfortunately, still today in endodontic journals, this is the kind of advertisement that we observe, which is against totally against any biological evidence. So gutta perfect, and it is the drawings showing the tree, the ramification filled with gutta percha. And again, well, Buchanan, all ramifications should be sealed. No way, no way. So I hope that the dental profession start to understand what is particularly important. Success rate, let me tell you, depends on two exclusively factors. The first one is the pre-existing microbiologic condition of the root canal system. So when we have vital cases, vital pulp, we have no bacteria and we have a pretty high success rate with endo treatment done by endodontists. We have 95% success. When you start with necrotic pulp and infection, success rate decreases to 80, 82%. And the reason is what I have been showing you, is the presence of bacteria, location of bacteria into areas that are not accessible to our root canal instrumentation procedure. So it was too fast, but I hope that I gave you the correct overview. Now, the second topic interconnected with the lateral canal sheath is the apical limit of the procedure. Schilder insisted for the radiographic apex, and Dr. Tayyan mentioned the terminology radiographic apex, but Schilder admitted many years ago that if you are at the radiographic apex, your instrument is a little bit beyond the limit of the canal. Schilder knew that. Another misunderstanding in the literature is the cementum dentin junction. This is a nonsense. That still in textbooks today, it is mentioned the ideal point will be the cementum dentin junction. Please look at any section, longitudinal section cut through the main canal and foramen, and you will see that the junction is located at different level in the root, sometimes distant 3-4 millimeters one from the other. So come on, this is it's a nonsense saying that the ideal point is the cementum dentin junction. It is against the anatomy and the anatomical observation. So please forget about that. The right place where you finish your procedure is the constriction or minor diameter, regardless of the combination of tissues that are present on the opposite side. There could be dentin, there could be cementum dentin junction, there could be cementum, I don't care, because the pulp tissue does not change when you go from the canal to the periapical area. It is the same, it's connective tissue. So if you stop at the apical constriction, you are producing a wound. Forget about drawings, let's go to human teeth now. The terminology is this, radiographic apex is there. Okay, so the foramen is there. The foramen is, what does it mean? Foramen is the opening. We don't want, is the foramen the objective of our measurement? Of course not. Okay, cementum dentin junction, as I told you, they are located at different points. So this is meaningless. And when you have a periapical lesion, remember, you always have some kind of resorption of the root. So radiographic apex is here. You want to feel, you want to instrument at the radiographic apex. Come on, I hope not. Then you have the foramen. You want to feel at the foramen? No, because it is a funnel. It is opening externally. And I do repeat, these are not drawings. This is the reality in human. The apical constriction is here. And this is the right point. Is it short of the radiographic apex? Yes, it is short. And I know that endodontists, they have the psychological problem. They have the big drama. Oh, this is too short. This is not going to heal. It is not too short because the location of the constriction is at a certain distance short of the radiographic apex. How short? Don't ask me because the distance is varying. Then it depends on your clinical skill, on your apex locators to have. Today we have reliable electronic devices to help you. Anyway, look at the apical constriction. It's unbelievable. Do you want to instrument at the level of the apical constriction? Come on, I hope you forget that. Well, the last case, radiographic apex, it would be too long. The foramen is there. It is a funnel. you cannot clean something which is funnel shaped. Once again, the ideal point is the apical constriction, which is at a certain distance from short of the radiographic apex. Okay, now let's go to the, again, to the human teeth with resorption. You have a large lesion, you have biofilm in the canal. This is the detail. What do we have here? The biofilm is faced with a concentration of inflammatory cells, but the inflammatory tissue, as you can see here, in this particular case, there are no bacteria there. The bacteria are a little bit more coronal. So if you try to locate the apical constriction, this diameter here, okay, and you respect the established working length, bringing a certain number of increasing sizes of the instrument, you are producing what? You are producing a small wound. A small wound. You are cutting. This is a surgical wound produced into inflammatory tissue. So if you instrument, you remove this biofilm here. Okay, you remove the biofilm here, and you instrument and feel here, you understand that there will be no more biological reason for the lesion to be there. That's so simple in biological terms. It's a problem of infection, control of infection. Now, just to convince you, I hope that you do the same. When you have teeth to be extracted, I know anything about the history of these tooth. They seem to be, the canals seem to be treated in a reasonably good way. Okay, now this has to be extracted. Let's look at the mesial root. Okay, if I ask you, where is the apical limit? Where is located the root canal filling in the mesial root? Some of you would say, well, slightly short. Some would say, well, it seems to be almost at the radiographic apex. Anyway, nobody would think that this root is overfilled, looking at the radiograph. Okay, and this is the tooth just extracted and clean. So please forget this psychological problem. I can't understand endodontists insisting that it could be short. It seems to be a little bit short, but it is long. This is overfilling. Understand that, please. Now let's look at the distal canal. This seems to be 0.5 millimeter, 1 millimeter short of the radiographic apex. Let's extract it, and it is like this. So obviously it ends on the lingual or buccal wall, obviously, and radiographically it appears that way. Please open your eyes and open your mind, okay? Because endodontics is taken a wrong path. I become so passionate on that because I understand my profession is going in a wrong way. We should start to go back and learn biology and root canal anatomy. Now, how do we measure the working length? I published a classic paper with my mentor, Professor Langeland, in '98, so 22 years ago, and we said at that time apex locators were not reliable at that time. So we didn't rely on, but today, the successive generation, they are pretty good. And now I think that this device, I don't want to advertise anything, all of them are good. This is the most common in the world. So you know that you have this line, the end of the blue scale, okay? Or you have the end of the green. The zero reading is at the middle of the green color according to the manufacturer. Some people want to stay at apex, but what apex? Probably they mean foramen. So if I ask to all of you, where do you establish your working length? I am absolutely convinced that most of you would say, I go to the apex, I go to the pink scale, and then I withdraw the instrument by 1 millimeter. And then I say, it's not clear to me. What is the reason for doing this? Why are you invading? Are you invading the periodontal ligament and then you withdraw the instrument? When the machine, it is telling you where the constriction is. These devices, all of them, the modern one, they can measure, they can tell you the moment when the tip of the instrument is leaving the canal. When the tip is no longer surrounded by dentin, they tell you. And where is that? Here. This device is at the end of the blue. So now you are at the apical constriction. And it is amazing that not even the manufacturer, they have the courage to admit that in the brochure. So there is a big confusion, but this is the point to adopt. And I do insist, don't try to go beyond, particularly in necrotic cases. You don't need to go beyond. You stay at the constriction. So you stop there, you take 3 consecutive measurements. If the machine gives me the same measurement, this is my working length. Just to give you some example. Okay, you have a periapical lesion, you have resorption. Okay, this is my working length. Is it short? Radiographically, it is short of the radiographic apex, but it is the machine that tells me that I am at the constriction, and I trust the machine because I know the machine very well. So stay there, no patency. Patency is another unbiological concept. So bring a series of instruments here at this working length, feel at the same level. As you can see, I was instrumenting up to number 55. Feel there, you have a drop of cilia. The cilia we cannot control. And after 3 years, you have the healing. So this is clinical treatment performed based on anatomical and microbiological and biological conditions. So what is the healing? Now, this is an experiment I did almost 35 years ago in the human. At that time, we could do that, not today. And this is a maxillary central incisor with irreversible pulpitis. The canal was instrumented 2 millimeters short of the radiographic apex. No locators at that time. Irrigation, 1% calcium hydroxide medication. And then after 82 days, a biopsy of the root tip with the surrounding bone was taken. Okay? So I do repeat, these are not common to find, but the information you can get is so important because you have the wound here. And what is on the wound? You find some scattered inflammatory cells below the wound. And then you have a small layer of necrosis. This is obviously the surgical wound, and it is the cumulative effect of what? Of the surgical cut, sodium hypochlorite, and calcium hydroxide. So when you feel, you have to keep in mind that you want to just to adapt your filling material at the wound, and the inflammation disappear in the absence of infection. But if you go a little bit apically, you find no more inflammation, only fibroblasts and fibers. And now, think about the concept of patency. You have been doing your best to produce a clean wound at this level. And then you bring your patency file with the intention to disrupt and to avoid accumulation of debris. You are doing what? You are destroying the tissue that you are trying to keep vital. So at least in vital cases, the patency concept is totally wrong. Okay, now, cases treated many years ago, about 1 millimeter short, okay? Lesion, 3 years, no lesion, perfect healing, okay? At that time, a biopsy was taken, and I can show you the histology of this case. And this, when we say healing today, this is what we mean. These cases are so precious for us because they allow to understand the healing dynamics following root canal treatment. And if I need an endodontic treatment in my mouth, I want to be treated this way. And now you will see why. Look, when do we speak about histological healing? When we have bone regeneration with normal trabecular bone, and you have it. You have normal periodontal ligament of normal width without any inflammatory cells in the periodontal ligament, and you have it. So this is the histological feature of healing. And then in the apical portion, since you remember from the radiograph, the obturation was slightly shorter of the radiographic apex, you have what? You have deposition of newly formed calcified tissue. Call it cementum sometimes. You see, after 3 years, this cementum is forming concentrical layers of in an attempt to close the apical foramen, but this will be never closed. But this is not important. What is important is that you should not have any inflammatory tissue in contact with the obturation material, and the apical connective tissue should be connected with the periodontal ligament without any inflammatory cells. This is the healing. Let me show you some other cases that failed restoratively. Okay, this is a disaster. 2 years and 5 months only following treatment. The treatment is a little bit short. As I told you, we want to stay close to the constriction, but this is perfect, radiographic. Okay, this tooth is lost, so we use this teeth to analyze histological, and this is short. Look, what I told you. You have the tissue is torn because of the extraction, but you have some minor debris, dentin spicules, and healthy, non-inflamed connective tissue. So this is what happened when you respect. The distal root, same story. You see, this is short. The foramen, pay attention, is anticipated compared to the radiographic apex. And again, formation of cementum, narrowing the foramen, and absence of inflammation in the periodontal ligament. I would like to conclude, I have time, with the last case that was treated by an excellent endodontist from Germany. This is the pre-op. He was able to locate all the orifices, okay? He instrumented all the canals. MB2 was there and filled in one visit according to the Schilder technique. Pay attention, this is the protocol that my colleague used. 5% sodium hypochlorite. A 0.8 K file was used to do patency, okay? He did patency. Then final irrigation with 10% citric acid and then 2% chlorhexidine. And these solutions were activated with ultrasonic for 20 seconds each. So this is a modern protocol, okay? One visit endo with patency file. And then Schilder technique. 6 months later, the lesion on the palatal healed. The lesion on the mesial root is still the same size, but the tooth was asymptomatic. 18 months, the mesial lesion is increased in size, so and the tooth is symptomatic. So this is a failure. And this colleague asked me how to take the biopsy because now surgery is indicated. So we have a failure on the mesial root. Okay, so the lesion is big and the lesion is elevating the floor of the maxillary sinus. So he took he did the apicoectomy. I told him to give me the lesion together with the root tip, and he succeeded. This is the unifying MB1, MB2, MTA, and this is the post-op. And this is what I received in my laboratory. So there is a cavity, so the lesion is a cyst. Now, I decided to cut longitudinal sections encompassing the MB1, MB2. And you will be impressed because this is just the overview. The lesion was a cyst, but please look at the apical anatomy. And here you have the detail. You have one, 2, 3 ramifications and another ramification connecting MB1 and MB2. Remember, this guy, this clinician was doing patency. But you clinician, you don't know that you have this anatomy. The main canal is bifurcating into 2 equal ramifications. So let's imagine that he was passing through one of the 2 ramifications for sure. And at the moment that he did this treatment, he was disrupting the biofilm, no doubt, because he did patency. But after 18 months, the biofilm completely recovered, filling the apical portion. So what is the reason for the failure now? For this, it's simple. It is the impossibility by the clinician to completely clean, remove the biofilm from the main canal, from the ramification, despite your illusion that using ultrasonic agitation of 3 different solutions, 5% sodium hypochlorite, chlorhexidine, and citric acid, you can get rid of the bacteria from the entire root canal system. There will be cases where we fail in this, and this is a typical case, despite he is a good clinician. Now, once again, success rate depends on exclusively 2 factors. Preoperative condition, that is long-standing infection of the root canal system. Number two, the preoperative root canal anatomy complexity. And you understand that if you have a single round canal, even if it is full of biofilm, you can get rid of it. But if you have biofilm in this complexity and in areas that cannot be reached by your instrumentation in your area, we are going to fail. We succeed surgically because surgery is removing physically the apical portion. So I think that I am confusing enough your mind today. So I will be here for your question. I will be here to answer. Here you have my email address. Write to me for whatever question. If you want to have more, let's say, easy reading on Facebook, I have several posts on apical limit, on lateral canals. My page is open to everybody. And also, if you want my publication on the topic, just you ask me and I will send you the PDF. Anas, I don't know what is next now. Questions comes now or later after Diogo presentation?
Many thanks, Dr. Ikuji, for this nice lecture. Can you hear me well?
Yes.
So many thanks. It was very nice to listen to you. Actually, I do have a few questions concerning this lecture. First, I would ask, we do have, in fact, some cases in which there is overfilling, as I already presented one of them, if you see my case. How can you explain the success in these cases?
It's so simple. You have been removing all the infection from the canal. So it's simple. So in the absence of infection, I told you, you are not killing your patient, but biologically, you are creating some damage.
Do you think that overfilling would delay the healing process?
Not exactly, because not exactly, because you may have the bone surrounding your extruded material. Now, gutta percha and conventional sealer, they do cause some foreign body reaction. So if I have the possibility, and I did for many cases, if you take histological section and you analyze, you will find surrounding particularly the sealer some multinucleated giant cell, foreign body cells. So this is something that will remain, but it remains a subclinical level. This is an inflammation that will not be detected on the radiograph. So on the radiograph, you have nothing. So I told you, so this is according to biological principle, you try to give the minimum damage to the tissue because you succeed equally. This is the difference between the two treatments. I told you, in the absence of infection, everything heals.
And do you think that a mechanical, overfilling, if we can say overfilling, would mechanically irritate the apical tissues? The periodontal apical tissues, and would it cause a postoperative pain in a way or another?
No doubt, no doubt. If for example, all people who do patency on regular basis in their protocol, and they use 5% sodium hypochlorite, the postoperative pain is much higher than people who stay inside. Yes. So it depends on the level of my goal biologically would be the best to produce a collar, to produce a stop in the dentin around the constriction in order, because at that time you create the less damage. Obviously, many people say, yeah, but then the beginner, the students, they will create accumulation of debris. Yes, and then you teach them that they have to do frequent recapitulation with smaller instruments. So you can prevent accumulation of that. Obviously, it's a matter of hands. Endodontists, they have the hands.
One more question, actually, concerning the apex locator. Just in case if your apex locator showed a very short working length, would you go for it or would you do another approach?
Yeah, correct. This is a good question. There will be cases in which, still a minority of cases in which your apex locators is giving you something strange. So when it tells you apex or constriction for 5 millimeters short, then you have to think there is something strange. So stop, take radiograph with the instrument under different angulation, and then you have to think that there could be a large lateral canals. So this is usually the main reason for this. But then in these cases, you have to use your clinical sense, your experience, your skill, because we don't have 100% success in electronic measurement.
Many thanks, Doctor, for your answers.
You're welcome.
We're very pleased with you today. And actually, I will share the screen now with Dr. Anas. Dr. Anas.
Yeah, dear Dr. Tayyan, it's a great pleasure that Dr. offered us this presentation. Thank you a lot, Dr. Rikuji. It's a great one, Damascus University now, with all the pleasure and thankful. Dr. Yeah, with all the pleasure and greeting and thankful, we will introduce Dr. Diego Guerrero, postgraduate resident in USA, Michigan, clinical tutor in Michigan, and now he's a visiting professor in Ontario, Canada. The title of Dr. Diego is about vertical compaction. I really apologize that we changed the title 1 or 2 days before. Thank you a lot. I understand that you made your effort. I really thank Dr. Manal, also Manal Zebar from Michigan University. She arranged the coordination. Thank you a lot, Dr. Diego. You can start your lecture by share screen.
Thank you.
And we are welcoming you a lot.
Thanks, Anas. Let me share my screen. It's disabled at the moment. So thank you so much for having me. Thank you, Dr. Tayyan. Thank you, Anas, Dr. Abdo. And thank you also to Dr. Zybak, which was my colleague at the University of Michigan. She's a graduate from Damascus University, so a big responsibility to be talking to her colleagues. And she's an outstanding endodontist. I hope you can have her soon speaking to you. I'm not connected to any school. I was in Michigan as a resident. I graduated in Michigan. I was an endodontist originally back in Portugal, but I am mainly a clinician. I work full-time as a clinician nowadays. And the topic for today is considerations about obturation, some tips and tricks, more of a process-based presentation than a disease-based or patient-based. Today, it's more about tips and tricks clinically on how to do things. Doesn't really matter. Doesn't really mean that this is the correct way. There's several ways to do every step in the endodontic treatment. And we have to start. Before starting with the obturation, I would like to start by the decision making. Endodontic treatment is a process of a sequential process of several steps where decisions are important to take in consideration, and we cannot consider, because it's sequential, that one decision is more important than the other. But we have to understand that one decision affects the other. If your access is wrong, it's very hard to clean and shape the canals. If you don't shape, if you don't disinfect, it's not the obturation that's going to save the day, and so on and so on. So fundamental of endodontic treatment and the importance of all stages. Basically, what we're aiming in terms of treatment objective is to obtain mechanical objectives and biological objectives. Obviously, it is a disinfection procedure where we go inside a root canal system space that's contaminated, and we promote disinfection. There's a threshold that we actually don't know, but what we aim to is to lower the number of bacteria to a threshold that allow the host response to heal the pathology associated with it. Obviously, when we have that classical image of a root canal funnel, it's not what it is in reality. This is some of our work in Michigan about micro CT tomography. Especially, my work was more on mandibular premolars with complex anatomy. But we can see by microtomography and the works of so many people that canal anatomy is pretty complex, and it's not. We have to understand it's almost impossible to think that we can reach all areas and disinfect all those spaces. Examples of mandibular premolars with complex anatomy. This case is a premolar with 3 canals, periapical lesion present, and after 7 years, it's asymptomatic. We can see still a radiolucency at the distal aspect of the root, but asymptomatic, so considered success. Another premolar with a complex anatomy. This one was particularly fun because there was a separated instrument inside the canal, so more challenging. But nevertheless, it's are those cases that makes us understand how difficult it is to get into all those spaces, to disinfect and to actually try to control the infection. Another molar, and these cases are just to show how the diversity of anatomy can pose a challenge to the endodontic treatment, not only in terms of diagnostic, what it looks like a straightforward case, a molar with 4 canals intermolaris. It's always a challenge. And before we talk about obturation itself, just to emphasize that it's important to recognize that we do what we can do in terms of disinfecting these spaces. But we have to admit that, and again, the success rate around 82%, we have to admit that some cases will eventually fail and most likely have a surgical resolution after. So before going to obturation, sequence that's important: cleaning and shaping the root canal the best we can, doing a final irrigation protocol, drying the canals, obturating the space, and then restoring the tooth back to function. Talking specifically about obturation, and sorry if I'm going too fast, trying to get into the time limit frame, and obviously open to any questions at the end. In terms of obturations and the objectives of our obturation, again, it is recognized that a complete sterilization is impossible, and even removal of all pot debris, it's almost impossible to achieve. We have to acknowledge that. Our instruments, all the studies from micro CT show that our instruments don't touch all the walls, don't even matter if we have isthmus, fins, or lateral canals. It is impossible to scout those canals. It is impossible that our instruments, even with the improved metallurgy, that they reach all those areas. What we do is an enlargement and try to provide a space where the irrigation can go and can reach those areas that are untouched by the instruments, and we rely on the irrigation to clean those areas. Again, the shaped and clean space represents the environment where these microbial communities have been eliminated or at least disrupted to that threshold that I was talking before, and can no longer promote the periradicular disease and hopefully allow a host response in terms of healing. And even though we lowered that threshold, of course, there's microorganisms, and like Domenico just showed with those beautiful images, they remain inside the canal. Even if we do those either SAM images or histology pictures, dentinal tubules are contaminated most of the times with bacteria, even after cleaning and shaping. So in terms of obturation, the result of cleaning and shaping must be maintained. The objective is we clean and shape that space the best we can, and then we seal to prevent the entry of microorganisms or fluids into that canal system. So our objective is to maintain the results of our disinfection procedure in the root canal. So just an image of an MB2. we enlarge in order to disinfect that space, and we seal that space. And that's our objectives in a root canal procedure. So talking specifically, and now getting into a more of the process centered, and I hope this is helpful for someone. Maybe for others this is too basic, but talking a little bit about a vertical warm condensation, and I'm going to talk specifically about vertical warm condensation because it's the technique that I'm using nowadays. Again, we can be hours here discussing or discussing the literature and comparing several obturation techniques. Again, I don't personally think it's the obturation itself that matters if the cleaning and shaping was not properly done. So I'm just explaining here vertical warm because it's the technique that I use, and I'll try to explain why I used it. So the vertical warm condensation was introduced initially by Schilder in the 60s, and obviously nowadays there's modifications to that initial Schilder technique, but two important concepts on vertical warm condensation, which is the down pack and the backfill. And the down pack is basically when we take an electric heated plugger into a seated master cone, partially melting it and pushing the softened gutta percha into the apical and lateral direction, and that's the down pack. The backfill is after, and this is an image of a tooth that we cleared. Not the best because the tooth cleared are a little bit soft, but just to demonstrate the heated plugger reaching the apical portion and melting and pushing the gutta percha apically and laterally. The other part is after we have that apical plug of gutta percha, we're gonna fill the canal with softened gutta percha, as we call it, a backfill of the remaining of the canal. So there's plenty of devices. I have no financial interest in any of them. Use whatever suits you best, whatever is available in your country. There's several systems that provide this down pack and this backfill. Elements is one of them. Calamas is another one. There's BNL2 with the alpha and beta for down pack and backfill. Whatever, they all do the same. I mean, whatever you're more comfortable working with if you're using this technique, I think that's what's important here. So if we compare the different obturation techniques, if we compare cold lateral to vertical warm to carrier-based obturation, apical ceiling, there's no evidence that shows that obviously one is better than the other. What we can talk about is about sealing ability of lateral, vertical, and carrier-based. We can talk a little bit about three-dimensional obturation. And again, like Domenico said, we endodontists tend to have this tendency of evaluating radiographs. And obviously, the quality of a dense field in a root canal gives us a hint about the quality of treatment, but doesn't mean that the cleaning shaping was not properly done. And so nowadays, there's no evidence that shows that if you use a lateral condensation correctly, if you use a carrier-based condensation correctly, if you use a vertical warm correctly, they all work. So I'm not telling any. I use vertical warm because in terms of three-dimensionally feeling and feeling the space three-dimensionally, for me, I think it's the technique that provides me at least a better conscious of that I'm doing the proper thing. Regarding extrusion, extrusion of gutta percha and sealer, regarding the technique, I used at a point of my life because my formation back in Europe, when I was in Europe, my formation as an endodontist was made with Italians, and the Italians back that day, they were very advocate for carrier-based So for a long time, I did carrier-based obturation, and carrier-based obturation is sold as a very simple technique, but actually the learning curve in order to avoid extrusion and to have apical control, it's pretty much more complex than one may think. I used it for a long time. Again, I am one of those clinicians that I like to keep my material inside the canal. I don't like, it's not that the extrusion of sealer or the called puffs can happen as a result of the hydraulic pressure that we place irrespective of the technique, but it's something that I like to avoid. From a biological perspective, that's how I was taught. So that's what I prefer. Again, when we compare vertical warm techniques to, let's say, carrier-based, it provides a better apical control of the operation materials. One of the reasons that the vertical warm for me suits me better is because when we as endodontists get complex cases that we need to feel, it's hard to feel cases like this. And again, doesn't mean that it will not work as long as the cleaning and shaping was properly done. But cases like C-shaped mandibular molars, a very rare case of a C-shaped upper molar. These are the cases where you want to thermoplasticize your gutta percha to fill those voids. Again, another case where there's a separated instrument, you bypass the instrument, and there's clearly isthmus between the two mesial canals. You want to try to plasticize the gutta percha to fill that space in order to provide a tight seal. Other cases that it's important to use thermoplasticized gutta percha. It's important, or with other techniques, it's very hard to fill those spaces, internal resorption cases. So these are the cases that have clearly indication for a vertical warm and a backfill with injectable gutta percha. So talking a little bit about the clinical sequence of a vertical warm technique. Again, we after we clean, our cleaning and shaping stage is complete, we do our final irrigation protocol. My final irrigation and I call it final irrigation protocol because and I see when I was teaching either in Lisbon or at the University of Lisbon or even in Michigan when I was teaching undergrads, there's this well, this doesn't happen with endodontists, but there's this concept of when you're a student that, oh, you shape the canal, you use the last file, okay, can I finish, can I operate? Well, when you shape, when you have the final shape, that's the time, that's the proper moment to take time to disinfect the space and to use all the potential of irrigation to reach all the spaces that you created. So that's what we call the final irrigation protocol. Is after shaping the canals, after the enlargement, you're gonna take the time to let the irrigants act, and you can activate those irrigants. You can just do needle irrigation. You can do manual dynamic agitation, sonic activation, ultrasonic, whatever suits you best. There's plenty of evidence in terms of computer fluid dynamics nowadays that obviously ultrasonic activation enhances the distribution of the irrigants. So this is the time that we have to provide that extra disinfection before going into the sealing phase of our endodontic treatment. I personally use sodium hypochlorite 525 followed by 17% ATA. I activate ultrasonically both of them. I also use the manual dynamic agitation after doing my cone fit, and then I finish again with 525% hypochlorite. I'm not. I know there's lots of people that use alcohol as a ladder irrigant in the root canal. I personally don't use it. Nothing wrong with it. If you want to use it, go ahead with it. So after cleaning and shaping is complete, after we do this final irrigation protocol, after we dry our canals, we're going to start the operation phase. And we're going to start by doing what we call a gutta percha cone fit. Nowadays, lots of systems that you use they have a matching gutta percha for the system. So let's say you finish with a master apical file next to from ProTape or next. The system has a gutta percha that that fit within the margins of error. That system doesn't mean that you have to use them. You can use ISO if you want. You can use feathered tips. You can use whatever gutta percha you want. I prefer to use this tapered. If I use a system like this, I prefer to use the taper, because on a vertical worm, the mass of gutta percha with tapered gutta percha it's higher. So for me, it's easier to do. But whatever fits you. There's several systems. Every system has its own matching gutta percha. You can use accessory sizes, fine, medium, medium, fine. You can customize, and you can cut your gutta percha to your preparation, and not the opposite. You don't do a preparation to feed a cone. You feed a cone to the preparation that you did. So the gutta percha is trimmed around 0.5 to 1 millimeters of the preparation termits with a tight tug back, meaning you place it and you have to feel that it's tight apically. Now we have this concept in our mind when we do this, that orifices or the preparation is round. Sometimes it's not round. Most of the times probably it's not round. It's oval. But at least that tightness is in two of the walls of that oval shaped canal. One of the common mistakes, I mean, this is kind of basic, but sometimes happens more for general practitioners, and it's something when Anna's asked me to do some clinical tips and tricks, this came to my mind, because it's something that happens is when you do a preparation and then you use those gutta percha cones that match, and you're going to do your cone fit, and your cone fit, you put a reference point on your gutta percha, you measure, let's say 25 millimeters, your working length, and you measure, and it goes over the apex. And some colleagues, the tendency is, okay, so let me go a number higher in terms of diameter and taper. And obviously, when you go a number higher, you're short of the point that you decided as your terminus of your preparation. So what to do is, a simple trick is to measure, obviously, the cone that matches your preparation, measure that distance. And then if you have that total measurement and you take your distance of your preparation, you find how much of that cone you need to cut, and you custom cut that cone to fit your preparation, and have that important tug back before you proceed with this vertical worm. It is important to have this tug back in order to avoid extrusion of gutta percha and sealer throughout the foramen. It's something that you don't want to do, and it's important to have this apical adaptation of the cone pretty well done. This is if you use this type of matching gutta percha. If you customize your cone from ISO or from one of those accessory fine, medium, or medium fine, it's rarely happened because you're customizing it prior. But whatever suits you. Again, I recommend if you're not sure where you are, always to get the information, take a radiograph and confirm. Again, radiographs are two-dimensional images, like Domenico showed in those extracted teeth. Sometimes you think radiographically you're even flush or you're short, and the gutta percha is out. So gives you information, not the most accurate, but if you need, take an X-ray to see that. So we fit our gutta percha cones inside the canals, and then we move into the selection of our pluggers. Two distinctions here: there's electrically heated pluggers for the down pack, and there's hand pluggers to pack the gutta percha. I personally, what I do is I select the heated plugger before I put it in my handpiece, whatever it's Elements or any other brand. I like to put it in my finger and take it to reach a point of 4 millimeters of my terminus of my preparation. Again, I don't want this plugger to bind to my walls. I don't want to provide any wedge effect that can lead to any overstressed on the root canal walls. I want it to slightly touch at 4 millimeters. So I try which one. Again, if you use the same system for shaping and you use, it becomes kind of automatically which one you use. But if because there's variations of anatomy and you might change systems there here and there, always try to do this selection prior to do the operation or the down pack. So basically, we use this heated pluggers to melt the master cone fitted to lengths. And after fitting this master cone and confirming the tug back, a hand plugger and a heat plugger are selected for the root canals. The goal is to fit these pluggers within about the hand pluggers too, in order to pack the gutta percha 4 to 7 millimeters of the apical constriction. Apical constriction, the terminus of your preparation, better said. And the depth of plugger should bind the marked rubber stops. So use rubber stops to know where you are in the canal. After activating the heat switch, the electrical power plug is driven into the seated master cone and basically melt it and push the softened gutta percha in an apical and lateral direction. The plugger should stop at a pre-measured depth and held for several seconds to compensate the shrinkage of the gutta percha. And then we stop that activation, we let it cool, and after a briefing activation, we do some apical pressure. It's hard to put it in words. It's much easier to show it, but hopefully you understand. But there's several videos of it. It's easy to understand. So after we stopped the heating with the stop at our binding point, those 3 to 5 millimeters from our preparation, we activate the heat again, do a little electrical pressure, take it out, and remove partially the gutta percha from the canal, leaving apical plug that's thermoplasticized gutta percha that we're going to pack in that 4 millimeters of apical anatomy. That packing is done with end pluggers. I personally like to have 3 sizes: one for the apical portion, one that reaches those 3 to 5 millimeters, and then one for my middle third, and another one for a larger one for my coronal third. After this is for the selection of the pluggers. If you are going to select the placing the sealer after, the selection of sealer, it's something that I leave completely to your discretion. You can use a resin-based sealer, you can use zinc oxide-based sealer, you can use a bioceramic sealer. Personal preference, I like to use resin-based sealers. Worked with, I'm not, again, for this technique, now there's a calcium silicate high flow sealer that you can do vertical warm with it. I prefer the resin-based sealers myself, but I guess if you understand the biocompatibility, ease of use, and it's a personal preference, I guess. Doesn't really, as long as the sealer meets the objectives while we're using it, doesn't really make a difference. So after sitting the sealer, I personally don't like. There's people that use paper points to place the sealer inside the canal. There's people that use it with the master cone. I like to put my sealer on my master cone, but I don't like to pump it. And I don't like to pump it because if I pump it, I'm gonna have sealer extrusion for sure. It's something that, again, like I said before, if it's a consequence of my hydraulic forces and it happens, it's okay. But it's not something that I'm looking forward to. So I don't like to pump that my master cone with sealer. I just sit it at my working length, confirm the stuck back, and place a little bit of sealer. Again, when we do other techniques like lateral condensation, because the sealer will feel some voids. The amount of sealer, it's much higher in those techniques than in the vertical worm. I don't think we need that much sealer on a vertical worm. So also controlling the amount of sealer and avoiding that pump will avoid the extrusion of sealer outside the canal. So doing the down pack, taking that that heated plugger, electrically heated plugger to your seated master cone with sealer inside the canal. There's several techniques. One of the techniques called continuous wave. So what we do is we take our heated plugger in one continuous wave to our binding point, those 3 or 5 millimeters of the working length. We do those 3 to 5 seconds, wait to cool down. We heat it again, push it up, and leave that 4 millimeters of gutta percha thermoplasticized that we're going to pack apically. And this is the image of after doing a down pack, the image, radiographic image of how it looks like. There is other techniques. There's a technique called vertical compaction. Vertical compaction differs from a continuous wave because instead of going in one one time to my binding point at the 4 millimeters, what we do is we go incrementally from coronal to apically, removing the gutta percha and packing. I like to do this type of technique, especially when I have very large canals or when I have oval canals, so distal or palatals that are very large, distal on mandibular molars or palatal on upper molars. I prefer this to continuous wave. So we remove a little bit of gutta percha and we pack it down, and we remove a little bit more to the middle third with the heated plugger, and then we go with a hand plugger. And every time you use the heated plugger, obviously the gutta percha is going to be plasticized, so you pack it down until we reach basically those 4 millimeters, leaving that apical plug that we're gonna pack to. So end result is pretty much the same. It's just when you have very oval canals, it's hard to put the plugger in a continuous wave in the center of massive gutta percha. So basically pushes the gutta percha just to one side unless you use more than one cone, which you can also do. But I prefer to do a vertical compaction instead of a single wave of obturation. Just a little video of what we talked about. This is a continuous wave. So we put the heat plugger, take it in one stroke to our binding point, wait a few seconds, let it cool, reheat again, apical pressure, and remove. And we have the gutta percha sitting apically, thermoplasticized, that we're gonna pack down in order to condense it tightly in those apical millimeters. After that, we're gonna do a second stage of the vertical worm technique, which is the backfill, and consists of injecting gutta percha in the remaining of the canal. You can do it by increments. I prefer to do it by increments. There's people that prefer to do it in one way. To avoid voids, I prefer to do it in several ways. So we inject a little bit of gutta percha and we pack it down with our pluggers, and that's the end result. Again, this case a little bit of sealer extrusion, not do it on purpose, but again resulting of the hydraulic pressure of the vertical worm. This is just a little video of the backfill of the remaining of the canal. I don't know, the video is, I'm a little bit laggy, so I don't know if the video is going on or not, but hopefully you can see it. And just a little bit, injecting the gutta percha and packing it down while it's still softening. Again, those little videos, it's a diaphanized tooth. So it's not the best example, but just to show image of what this technique goes. Showing you a case. It's a nice case for the outcome, but one case that I thought that obturation had. This was a few years ago, 2012. That I thought obturation had to do with the problem. But let me tell you a little bit about this case. It's a 25-year-old patient, non-contributory medical history, no drug allergies. There's a previous history of a pulpotomy with MTA, and he had a persistent pain on his jaw. The tooth obviously tested negative to endowise. There was severe pain on percussion, mild discomfort on buccal palpation, and no sinus tract was present, probing within the normal limits. So diagnosed with pulp necrosis and symptomatic apical periodontitis. Patient comes for treatment. This was a clinical image of what we found. So a leaked and recurrent decay composite filling over that. So remove that's what looks like the old NTA from the pulpotomy. Remove that with ultrasonic tips. Find the orifice entrances. Build up that pre-endodontic buildup. Again, I like to have that little pool for my irrigation to sit there during the treatment. So it's important to do this pre-endodontic buildup prior to the treatment, and an eventful treatment, doing the obturation stage here, 3 canals, pretty normal anatomy, nothing special. What was uneventful? The root canal. I'm just backing here the gonna push it back filling now, and this is the final result. So if you ask me, a little bit of too much of a sealer / gutta percha extrusion there on the mesials. Yeah, I agree. I was not happy, but was not sad either. It's something that we have to learn how to live with it. And obviously, I recall my patients for 3 months, 6 months, and a year, and after a year, every 5 years, if I can get hold of them. But so I rescheduled the patient for a 3 months follow-up. Patient comes in March 2013 for a follow-up, and he is symptomatic. So he says, no pain, no discomfort. I don't feel anything. Nothing bothers me. Meanwhile, he had done an overlay over the tooth, and I take this radiograph, and I found this radiolucency associated with it. So my first thought is, I don't think there was missed anatomy there. So maybe persistent infection. I considered some extraradicular infection. Maybe was it a foreign body reaction from my sealer extrusion? I didn't know. So I told the patient, well, cases like this, option is either to retreat non-surgically or to go surgically to treat it. At this point, the patient decided, I don't want to be put to a surgery, so I agreed to retreat it. Even though he had a new onlay and I tried to convince for surgery, he wanted to retreat the case. But he said, oh, well, I'm going on a honeymoon, so since I'm asymptomatic, we'll do it when I come back from my honeymoon. So when I saw him in March 2013 and I looked at the size of that lesion, looking at that first molar and that retracted pulp horn, I thought, is this tooth vital? Is that lesion probably originating from that distal root of the 4-6? But the tooth was testing completely normal to cold. So the problem was really with the 7. So he said he was going on his honeymoon. He was going to get married, going on a honeymoon, and he will come back after that. So this is just another angulation of that day of March 2013. So I have this chart for the emotional journey of creating anything great when you think this is the best idea ever, everything's going to be brilliant. But the reality is that sometimes you find yourself in that dark swamp of despair when you're like, I did everything wrong. The canals look clean. The obturation looks dense, looks to length, and you can explain it. Well, you can always assume that there's the treatment that you provided was not the best. So I called him back. He comes back in 2000. So this is the initial November 2012. He comes in March 2013 like this, and then he goes on honeymoon, and he comes back to me almost a year later, and that day it was scheduled to do the retreatment, and this is I take an X-ray that day, and this is what I see. So absolutely no symptoms, and healing of that image that we had at 3 months. 2015, 2016, 2017, and 2018 was the last radiograph I took of him. At this point, considered success. So this case just it's one of those cases that question my decision making, and question the decision making of doing a surgery at that point and doing a retreatment, jumping on a retreatment. If we hadn't waited a little bit, patient was asymptomatic. If we haven't waited a little bit, I would probably have convinced him to do a surgery on that tooth or doing a retreatment, and it actually wasn't needed. So just a case that questions a little bit of the decision-making process that we sometimes do in endo. Another nice case of this case is an incisor with invasive cervical resorption. These are the initial radiograph, some initial pictures, initial radiograph. There's invasive cervical resorption there. It's previously treated. Quality of obturation looks a little bit short and not dense. So it was decided to retreat. We get in there, we see this mushy, very contaminated space, remove the gutta percha, access the defect, the resorptive defect from the inside of the tooth, able to negotiate the canal fully, cone fit, obturation, sealing of the defect. And these are some clinical images. That's the resorptive defect right there. After the obturation, we decided to delimit the obturation below that defect and then fill it with a glass ionomer, and then the rehabilitation. This is Paulo Montero's work. He used to work with me. He's still in Portugal, so he's a teacher at the Agasmenes University. A very, 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 very good restorative dentist, and this is his work. So here's a 5-year follow-up of the case. So it worked. So it's just a nice case. And see, yes, any questions?
No, would you kindly just share your screen again?
Oh, there you go.
Okay, thank you.
Is it shared? Is it shared now?
I suppose so, yeah. Thank you. Can go ahead.
Okay. So can you guys see it now?
Are you presenting slides here?
I don't. Can you? I don't know. Let me share screen. Share. There we go. Can you see now?
Here we go. Many things. Yes, got back. Yeah. Thanks a lot. Yeah. I'm sorry for interruption.
No. Thank you for the interruption. I don't know where it stopped. I was talking.
Yeah.
I don't know if you.
No worry. I wonder if Dr. Rikuji have seen the last few slides.
Well, just a case. I put this case to show it's not a complex case at all, but shows, again, the CBCT, especially the sagittal view, shows the dense of the filling, and the follow-up at 5 years showing there's no considerable bone loss, especially on that resorption defect. There we go. The full case. So guys, that was it for me. This is where I work in Canada, Hamilton, and that's it. A little bit of a more technical than disease-based or patient-based lecture, but hope it was useful. Open to any questions.
Many thanks indeed, Dr. Guerrero, for this nice lecture.
Dr. Tayyan, you can start your discussion now.
Okay, I was. You hear me well? Okay. I'd like to thank Dr. Guerrero for his nice presentation. And I was just talking offline with Dr. Rikuji, and I asked him about his opinion with ThermaFill. And I believe that you covered this topic in your lecture. Just what I would like to ask you if you think that these types of technique would affect in a way the sealing of the root canal, because you know these types of technique has a plastic core, and many clinicians use them with curved canals. And sometimes, you know, the core is left alone in contact with the root canal, with the surface of the root canal. And in this way, we don't have good aperture to seal the root canals. I know that there are a few techniques now and new ways that have GP core. But would you think that the ThermaFill would affect in a way the sealing?
Well, you know, when the core, when the first plastic cores came out, people that advocated carrier-based used to say that, oh, it doesn't really matter if you have a curved canal and there's no gutta-percha in this area. But the truth is that if that wasn't the problem, they wouldn't have developed a gutta-percha carrier, right? The core based of gutta-percha, because that was a problem. Now, does that affect the outcome? What I don't have an answer for that. What I know is that lots of cases that we retreat of carrier-based, and every endodontist that retreats carrier-based knows it's a pain to take them out. But we retreat a lot of them. I don't think it's because of the obturation technique itself that the case failed. It's because the lack of disinfection of the space. So again, I used the carrier-based obturation for quite a few times. And what I like to say about carrier-based obturation is it's sold as an easy technique to seal canals, and the clinicians are not using it properly most of the times, because if you shape with 2% hand files, there's no way you can put a ThermaFill, but that's how it's sold, right? So I think the cases fail more because of misuse and misunderstanding of the technique than for anything else.
Not maintaining apical ceiling. I suppose, yes, I do agree with you. Another question concerning the vertical compaction technique you use. Do you prefer the pluggers you use? I know I'm asking this question concerning the use of microscope has made it much easier to see what you're doing.
Like I said, if you're experienced and if you use mainly one system or two systems, if you hybridize here and there, I mean, 95% or probably 90% of our shaping, it follows also in the same system protocol. So when you finish on an X or Y master apical file, you know which heat carrier will reach your binding point. So it's pretty much automatic. Obviously, there's variations. Now, if you're not as experienced and you're starting to do this technique, I really advise you to test the pluggers before, because you don't want to have the risk of doing that binding to the walls and that excessive force at the walls.
Okay, many thanks. And one last question concerning the using of alcohol as a final rinse. I missed this part of your speech. Basically, why you are not advocating the use.
No, it's not. It's not that I'm not advocating. It's something that I used in the past, alcohol as a final irrigant. I don't see any difference specifically to improve sealer penetration. For me, those are little details. If it helps dry the canal a little better, maybe increase the moldability. Doesn't really make a difference in my view. But again, it's one of those things in endodontics. There's so many things that we can say, oh, it's right or wrong, or this is, you shouldn't do this, or
do you think that those who's using this, the alcoholic as a final rinse, they're trying to push the material, the filling material in the
yeah. And that's something that I it's not my objective when I seal.
I see. So you agree totally with Dr. Domenico?
Yeah, I agree with Domenico with lots of things, and it's such a renowned researcher, and I've read his research, and I agree with a lot of the things that he says, and it shouldn't be, and I agree with him when he says that now we live in this world of Facebook and the show off more than caring about the patient and the outcome. And yeah.
Many thanks, Doctor. Many thanks.
Thank you so much.
Presentation, and very happy to be with you today. And many thanks for Dr. Ikuji for his nice presentation. It was very helpful and useful. And I leave you back with Dr. Anas.
I have a little question, a little piece of a question to Dr. Diego. 5 years ago, one of my colleagues is doing a research on fiber post in prosthodontic department. I asked him something. I said to him, please, will you please let me make the obturation for the premolars that you will do the fiber post in? And he agreed. I separated the premolars to 4 groups. The first is lateral condensation. The second is single cone technique. The third is vertical compaction, as Buchanan described. The 5th one is as Schilder described. I noticed that the method of Buchanan going down with the tip, the heating tip, 5 or 6 millimeters, then making the backfill, really it filled the canal from the point of the heating tip to the orifice of the canal. But down there in the apical area, it is either a single cone or a small heated single cone having some distortion.
Yeah.
I suggest we started to make a publication at that time, but we didn't continue because we made the X-ray from the mesial. It is extracted tooth, you see? So I noticed that really the heat doesn't go beyond the tip more than 1 millimeter. There is no condensing, and you know that when we go on 06 taper gota, or sometimes the auxiliary, which is the same as the rotary file, really it will not fit anymore in the apical area. Maybe in the incisors it could be, maybe. But in premolars, we have a calvus sac, and we have some fins, and we have some ridges here or there. It wouldn't be filled unless we compact and heat and soften the catabursha. And even in heat compaction, they ask us, the companies, to dry the sealer by paper point. So imagine in single cone they don't do this process. They fill the canal with the sealer and insert the single cone. I don't agree with single cone at all. But even with the Buchanan technique, we have really gaps surrounding the gutta percha in the apical area. Furthermore, one of the researchers, which is Taggers, I read his articles. He mentioned that in the past, even in lateral condensation, we should make 2 or 3 cones condensed in the apex, then use the catabursha condenser like Max Padden inventor to fill and compress. We really don't find this procedure in vertical compaction. So really, up to me, I don't believe that apical 3 or 4 millimeter, if we stop the heating tip before 5 or 6 millimeters, we are having a condensing or compaction in this area. And the splash of heat that fill the sealer in the lateral canals. This is my opinion. I'm wondering what Dr. Rikuji can say and what you can give us as a clarification or a point of view, Dr. Diego.
Well, for me, I absolutely agree that there's no diffusion of heat past that tip that much in order to soften that apical gutta percha. So yes, we're talking about probably a single cone in the apical last 3 millimeters filled with sealer. So now, compared, if you see lateral condensation, and lateral condensation worked for so many years and still works nowadays, right? Because you provide a apical seal on that last millimeters, and you do a correct restoration of the coronal portion of the tooth, and that's it, and provide success as long as you obviously cleaned and disinfected the space. So I don't think it really makes a difference. Makes us maybe think that we're three-dimensionally feeling that proxy of three-dimensionally feeling the root canal more than actually.
Yeah, the controversy.
If I can add something, do you hear me?
Yeah, for sure. You can go ahead, please.
Yeah, but just to say that we didn't mention in my presentation and in Diogo's presentation that the world is changing. So we didn't mention that we are shifting to the new bioceramic material to fill the canal. So it is very easy to anticipate that sooner or later we are going to abandon gutta percha, either warm or vertical or lateral, whatever. So most of us are already doing this. I have research on the histological results using bioceramic, and I have to say that they are really interesting material compared to the previous zinc oxide eugenol sealer, resin-based sealer. They are considerably better. So I think that we will not use gutta percha.
Yeah, Dr. Rikuji, that is a great that the new material, which is bioceramic, sounds to be good. But we have two problems. The first one is with heat compaction. With heat compaction, they are drying the sealer from the canal. And the sealer is the base thing of sealing ability. And we have no heat condensing really. The second thing is with bioceramic, they is advised not to use it with heat.
Exactly.
So with bioceramics, we are away of.
We don't hear you anymore.
Yeah, we lost you for a second.
I noticed.
I got part of your question.
Repeat that, please, Anas. Would you repeat that, please?
I'll repeat that.
Yeah, the first question is with heat compaction, vertical compaction. They ask us to dry the sealer from the inside the canal, and the sealer is the role of sealing ability and in tamping. And you believe, Dr. Diego, that heat compaction don't pass more than 1 millimeter of the tip. Is it okay?
I agree that it doesn't go.
Yeah, the second issue is with bioceramic. Bioceramic, we cannot applicate heat compaction with bioceramic. Well, so the compaction method, now we have bioceramic high flow. The compaction method is ignored with bioceramic. But Dr. Rikuji will say we can use bioceramic without gutta percha. Really, it's a new field of the world. And could the bioceramic be flow enough to fill the ramification and the anatomy inside the canal? Do the surface tension of the bioceramic is lower than the irrigation material? This is the question.
No, the problem is, once again, your position reflects the position of the mainstream. You can't free your mind from the, why do you need gutta percha? Why do you need warm? Why do you need to squeeze? You don't need to squeeze anything. It's so simple. Just place the fluid material and use your lentulum. And then let me conclude, please. Then, if you just want to think that one day you will reopen the canal, just place one single cone. It's so simple. And let me tell you, well, you know that I have no connection with the market. But the problem is, if you look at the response of the tissue, all these material are much superior compared to the old material.
That's right. I agree with you.
I anticipate.
I agree with you about the material.
I think that soon we will abandon gutta percha. This is what is happening in my practice because I saw the result. I agree with you that bioceramic is a superior material over the previous sealers and over the gutta percha far away. But we have a question. Do the surface tension of bioceramic is lower than any irrigating materials so that this material will fill inside the isthmus or the Calvis sac or be adapted without compacting? You put some cases on the Facebook, I saw them, but all of them is like very wide canals. Yeah, the problem is to find a technique that adapts the material, but given its fluidity, you know, it's so simple to apply this material. I personally just use a little bit with the syringe and then use a little bit, few seconds of with a lentular spiral, and that's all. And I can tell you that my clinical impression, this impression is not scientific, I cannot give you numbers, but let's forget the histology now, but the healing speed of the big lesion using this technique only with
the success rate is high.
Even shorter, it's much shorter. In 3 months you see big lesion healing, so there must be something. It is difficult to tell you what. Probably the high pH, probably the fact that they release calcium hydroxide. Then we have a lot of theory. I'm not an expert in material, but it is a fact that clinically they work. And let me tell you that the response of periapical tissue to this material is excellent.
Yeah. Sure. That was great. I agree with you really. Sorry, Dr. Tayyan. I agree with you really. But I have a question. Do we can advise people who prepare to the apex with apical patency with bioceramic, high flu or bioceramic without extruding the material to the outer space beyond the apex? Could we reach that? Up to your school, it's okay. Up to your school, it's okay. The material will not go beyond the apex. But the other school, they prepare to the apex, they fill to the apex. If they use bioceramic without any core material, can they inject the bioceramic without passing and exudating or let the material pass beyond the apex? Is it controllable? Do they can control this?
You want my response?
Yeah.
I don't care about that. They do what they want.
That's great.
Totally wrong. I have spent 1 hour to tell you that it is wrong. Now you want to ask me to come on, please.
Yeah. Great, Dr. Rikuji.
You create an apical stop and stay there. I don't care. They do what they want.
Really, Dr. Rikuji, my students, come on. I teach them really to go with apical seat, to go with your philosophy, because it will be more safe and more easy and more accurate.
Please don't call it philosophy, because it is not a philosophy. It is based on, so it is not a philosophy. And let me tell you that even I speak well about the bioceramic, but the adaptation of the bioceramic to the warm compaction is stretching the concept. It's stretching, because why do you want to adapt? Because you don't want to abandon the warm with the pressure. Then you have to modify it is another big mistake to me. It is another commercially oriented trend, which I don't like. So it's so simple. You feel a canal in 2 seconds. What do you want more?
That will be the best, really. Dr. Rikuji and Dr. Diego, I need